CHE, Senior Psychological Services. We provide psychological services currently in over 400 nursing homes and other long-term care settings, mostly in the Northeast, New York, New Jersey, Pennsylvania, Connecticut. And I've developed an innovative model of treatment that's based on other affect regulation models. It's got some similar techniques to DBT and EMDR. However, it really talks about the centrality of empathy in the therapeutic relationship, in reducing negative emotions, extreme negative emotions. So it applies very well for disorders of aging, especially dementia, but also other health issues. I firmly believe that extreme dysregulated emotions accelerates the aging process in many ways. And I'll give you some evidence about that today. So we can improve the implicit emotional response because the amygdala and other limbic functions are functioning longer than the hippocampus. And therefore we can make changes even if a person is not able to recall in an explicit way what happened. We're going to be moving this into an evidence-based model, and the research is still in its infancy stage, but because we're collecting a lot of data, we will have, because the forms themselves will be assessing cognition and mood and outcome from treatment, we'll have some data to report in the future. So what I'm going to be talking about today is actually a new paradigm in affect regulation therapies. It has a more of a neurobiological basis. There's some common molecules in the immune system, the endocrine system, and the emotion system. And there's also a general principle that we do much of the same strategies when we sense danger as a single cell does. We do it more complexly with greater capacity to regulate. And as therapists, we're putting into practice, therapists being what I would call a tuning fork, automating healthier, less extreme emotional and behavioral responses. I think there's a bias, certainly often in the dementia community, that people who have dementia can't respond to psychotherapy. Well, I'm going to show you a little bit about why they might be able to. First of all, there is a fairly accepted theory right now called the Cortisol Cascade theory of dementia that says people who are stressed all the time have high cortisol levels from stress all the time, and that this high level of cortisol is neurotoxic to the hippocampus, shrinks the hippocampus, and that's a very good model, but it's incomplete. There was a study done by Goldier et al. That looked at Holocaust survivors. They were surprised by their findings. They could tell that Holocaust survivors with PTSD would get dementia at a higher rate than average, but their hippocampus turned out to be intact, and their cortisol levels were not that different from other people. They might have been slightly low or normal. So I have a model that actually accounts for that finding, that the researchers were not able to integrate into their interpretation because they didn't have this paradigm shift that I've been talking about. The way that the cortisol cascade theory looks at hippocampus is sort of like a light bulb. When everything works well, your light bulb lights. You're getting enough current, you have an intact filament, and from the cortisol cascade theory, cortisol levels over a lifetime basically prematurely age the hippocampus and it shorts out. So the light bulb burns out. But I think there's another way, and based on the Holocaust survivor data that has pretty good suggestion of this, that the light bulb doesn't get enough power for another reason. It doesn't get enough power. It's got a damaged power supply, and I think that's the hippocampus deactivating under more profound stress rather than overactivating under less severe stress. There is a model that in the neuropsychoanalytic literature and the trauma literature developed by Alan Shore. It's called affect regulation therapy, and this is the model I'm presenting today. It's an outgrowth of, and I believe an improvement upon his model. He talks about this regulation from two extremes. The hyperactivation, let's see, do I have the, that doesn't work. Okay, is this the, okay. So the hyperactivation is a sympathetic nervous system fight or flight response, and basically you have a normal range, and when things get stressful, you sense danger, you go into hyper alert, flashback memories flooded with anxiety or anger, and after a while you say, wait a minute, this I cannot outrun this threat, I cannot neutralize this threat, so you shut down and go into hypoactivation and conserve energy. That's why the light bulb doesn't get enough current to light and you get dementia. It's a pretty good model. I think it's not complete also. I think Shor's model, first of all, does not make a discrimination between when you're in fight and when you're in flight, and it does not explain depression, only fight, flight versus dissociation. And it also really doesn't talk enough about aging and problems of aging. He talks more about childhood and how the brain wires under the context of safety versus non-safety. I'm talking about how the brain ages faster under conditions of not feeling safe. So here's the latest model. I believe it makes sense that there's the A's and the D's of affect, of emotion. So we talk about fight-flight. I think the difference between fight and flight, or whoops, wrong button there, sorry. Here we go. Anger or anxiety is one is the level of risk tolerance. Okay, so if you look at the level of risk tolerance, anger, you believe if you can have an offensive strategy, you'll neutralize the threat. And with anxiety, I believe you're conserving resources a little bit. You're getting away with whatever you have left. You're running away from the threat. And if you can't outrun the threat, very many people make the mistake that fear is anxiety and freezing as the same thing. I disagree. I think down here is dissociation. That's the next thing you do. Up here, basically, you've got a flooding of cortisol, and down here, you've got a flooding of endorphins. Endorphins allow you to bear pain. You get flooded with endorphins. It's a shielding in place because I can't do anything but basically cover my head and wait for the threat to go away, and I'm conserving energy while I do that. When you're running out of endorphins, you get depressed, you're defenseless. There's no way you have a very low level of risk tolerance, and there's nothing you can do but feel a lot of emotional or physical pain. This is a chart that kind of describes it in detail. It's kind of the heart of the presentation of this new model, that basically, in the middle, you feel safe, but you don't want to be too safe. You feel confident, but you don't want to be overly confident and make mistakes from being too cocky. Allows you to be strong, but not overpowering, and to have compassion and empathy. Okay, so that's where you have your positive emotions and optimal health. Up here, you're going to likely to have failures of the immune system, of underactive immune system. And here you're going to get autoimmune or an overactive immune system. Here you have less of the immune responses going on, but you still have difficulty in health and pain, and it's more, rather than the anti-inflammatory up here, it's the analgesics down below, the pain or lack of feeling too numb. Here, I actually believe there's another molecule, alpha MSH, that involves bonding. And when you have an optimal level of bonding, you stay close and want to be close, but you can be independent. You're not too clingy over here, and you're not too overly confident. So there's evidence to suggest all of these are related by one molecule that splits to those three different ways. So one way to strategy for danger is to activate, another is to deactivate, and there's a level of optimal engagement. I think that's true from a single cell all the way on up. I don't have time to present all the evidence on that, but there is evidence for this. This leads to what do we do about it? Being the treatment of the therapist, I really see it as a tuning fork process. We re-empathize. The previous speaker was talking about how the empathy and the relationship helps re-regulate the emotions, and I firmly believe that too. It seems to be done by mirror neurons. There's parts in our right orbital frontal lobe that when we feel a certain way, we radiate to each other, and the right orbital frontal lobe in the other person lights up the same way. So that means we could either be contagious in a negative way, if you're a therapist and the patient's going, oh my God, and you're jumping up and down, oh my God, you're both going to have more negative interaction and more negative. But if you can say, let's bear this, I understand what you're feeling, but name the response. It's a difference between if you're angry and if you're depressed or if you're anxious. So let's be clear, or if you're shut down and numbed out. To name these helps bring you out of the condition, because it increases your mindfulness. It re-regulates your right orbital frontal lobe to re-regulate the bilateral, both sides, amygdala, to then help the patient automatically have greater control over their emotions. So in order to do this, therapists must first feel safe and in the comfort zone in the middle, him or herself, in order to empathize and bear the intensity of these negative emotions. And if you do that, there's a improving of the autonomic responses, the heart racing or the shutting down. All of these improve, and instead your patient will get into the middle. The joke, yes, it's meant to be funny. So is this one here. The therapist really needs to bring a patient safely into the now, and it's something that we can always, it's elusive what the now means, the comfortable, but the point is to feel safe now, remembering what those traumatic events were then. And that improves the threshold of the amygdala's autonomic responses so that the person remains safe with these recalls instead of feeling an over or under activation threat. We might see it this way. Some people have very, very limited comfort zones. So no matter what, they're going to pop off with catastrophic emotional responses. We can increase the tolerance threshold so that a person eventually feels relatively safe in a somewhat unsafe world, because that's really what we live in. We have an illusion of safety. It's only relative safety. So expanding your comfort zone, you have a greater autonomic threshold before you feel a sense of danger. More of a confidence you can handle things. When you cross that bridge, you'll handle the problem. So it also matters what will make a patient feel better. And that also depends upon their preference. It's not just be happy. Some people prefer novelty, some people prefer familiarity, some people prefer stimulation, others relaxation, and most of us feel one of them at one time. We want more comfort, and other times we want more stimulation. So I believe the same chart that worked for the negative affect states works for the positive affect states, what will make me happy. And here you have, again, the activation versus deactivation. You've got the center, and there's the risk tolerance. You may be more conservative here, wanting familiarity, more progressive, novelty seeking here. And I think of the kinds of exhilaration you get are three kinds of things. One is I'm going home. The other is I'm a pioneer. I'm going to boldly go where no man goes before, the Star Trek, at the extreme, we're saying. And the other is bliss. Take me for a ride. I'll be your passenger. Give me a thrill, and I'll follow along with you. And that's more of an endorphin or a heroin high as opposed to a cocaine high. Here, an apathy is kind of more, don't make any changes, stay where I am. And that's wanting to be familiar. And so I believe that the positive affects are related to the negative affects with the same neuroendocrine responses, but one that's interpreted a positive versus negative way. I have two therapeutic techniques that I want to talk about. One is the concept, first still, and then stimulate. You want to calm the negative affects, negative emotions through meditation, mindfulness, compassion, especially empathy. That does the retuning. You also want to stimulate after a person is calm. You don't want to stimulate when a person's feeling anger or anxiety or depression or dissociation, because they will not pay attention to the stimulation. It'll change their response. So you want to do a positive life review. You want to help people feel pleasure at mastery of what they do. And the reality is we're seeing evidence that when somebody feels more stimulated, they actually grow more hippocampal neurons through increased BDNF production. And here's the final thing I say, all you need is love. Isn't that wonderful? Just need love. This is a step-by-step acronym, where L means look empathically to contain the intensity of the negative feelings. It's kind of like being an auxiliary amygdala. You're supporting the amygdala's functions. Then you're going to support the hippocampus. O means organized, emotional, and cognitive memory. And then you're going to want to help the person evaluate the effectiveness and to be the auxiliary right orbital frontal cortex, if you will. Then you want to evaluate yourself. E would be evaluate. Your own ability, and then repeat it or modify it if necessary. We all have to be very loving with each other. And that's the heart of this whole presentation. There's a whole bunch of theorists that went into this, but I'm mentioning their names rather than the copious references I can give you. There is a book in progress and research publications in progress, so it'll probably take a few more years for you to see that. Thank you very much.
Thank you very much. That was a lovely talk. We move from